one of the PAs here in the medical oncology division of the GU clinic, and I'm going to be talking about adjuvant therapy for patients with kidney cancer. So we're going to talk about what general treatment options, what the immune system is and what its role is here. When do we do immunotherapy after surgery? Who is this applicable for? What are the side effects? What does being on treatment look like? And then what if that isn't the right choice for a patient? So to start talking about adjuvant therapy, we have to know what that means. So adjuvant refers to treatment that's given after surgery. You may also hear of neoadjuvant therapy in some cancers, and that's given before surgery. But here in kidney cancer, we're giving adjuvant immunotherapy within about 12 weeks of your surgery to reduce the risk of recurrence. So look, in general, when it comes to cancer, you often hear about things like chemotherapy, radiation, surgery. Chemo isn't one that we use as often for kidney cancer, and there's other things like targeted systemic therapies that we use that we'll talk about more later today, but also immunotherapy. So how did we get here when it comes to kidney cancer? There were a lot of different studies done in the past to look at different treatment options that could work before a patient has metastatic disease to see what would be a good choice. And these, on the right side there, they're showing it's a whole list of 7, 8 different studies that were done in the past, usually using drugs that we used in the metastatic patients. But most of those studies didn't show reduced risk of recurrence. In 2016, there was a study using a drug called sunitinib that did show improved disease-free survival. And it was used some, but that particular pill did have a lot of side effects. It was harder to tolerate. So in 2021, there was a new approval from that trial called KEYNOTE-564 that looked at pembrolizumab, an immunotherapy, in that post-surgical time period to reduce the risk of recurrence. And that was a big game changer in this field, and that's now what we use as standard of care after surgery. So when it comes to the immune system in general, the immune system is a complicated thing. It's made of a lot of different organs, tissues, cells. When we talk about cells, there's your white blood cells. So looking at that picture in the bottom middle, your lymphocytes specifically, those are ones that can attack different pathogens and also attack things like cancer. So that's key to how immunotherapy works that we're putting to use here. And immunotherapy in general is a broad category of treatments. There's different types. Specifically, when it comes to this kidney cancer adjuvant space, pembrolizumab is what we call an immune checkpoint inhibitor. But we often just broadly call it immunotherapy, so you may hear those interchangeably. So later in this morning, you'll hear in a little more detail the mechanism, but I'll give you the broad overview now of how immunotherapy works. So your body has its own immune system to help figure out what belongs to the body that shouldn't be attacked and what's foreign material, whether it's bacteria or cancer that the body should be trying to get rid of. The cancer has ways that it uses to try to essentially hide from the immune system and stay in the body, keep those lymphocytes from attacking the cancer and helping destroy those tumor cells. But with this immunotherapy, we're able to take advantage of that drug to prevent that hiding of the cancer cells. So then the body is able to go out and attack cancer. So things like chemotherapy you may hear of, that's directly killing cancer cells. Here, immunotherapy is telling your body to go out and do that work. So that's a little bit of that difference there. So immunotherapy is relatively new. The first one was approved back in 2011, and we've had several approved since then. And pembrolizumab, or Keytruda, its brand name, that was one that came out in 2014. And all of these are used in different cancers, sometimes multiple, sometimes in combination with pills. But the only one that we use after surgery to prevent recurrence is going to be pembrolizumab. And this is just another similar diagram to the prior. So this study, KEYNOTE-564, what this was is that they compared patients who received a placebo to people who received pembrolizumab for 1 year after their surgery. This wasn't given to every single patient who was diagnosed with a kidney cancer. It had to be clear cell renal cell carcinoma, And they were giving it to patients who were thought to be at higher risk of recurrence. That's decided based on features seen in your surgery and on the pathology, what that cancer in the tissues actually looked like. And so there's a lot of complicated things on there, but if your surgical oncologist decides that your cancer was a higher risk cancer, then you may be referred to medical oncology to talk about immunotherapy afterwards to reduce your risk of the cancer recurring. Additionally, this also was used in patients who had one site of metastasis. So often we see, like, say, adrenal gland metastases close by, that's able to be removed as well. So then these patients, yes, they had some metastasis, but it was removed, and they're on scans, they're what we call no evidence of disease. So in them, they were also included in this study. And so looking at outcomes, we now have data from several years out from this study. And so the bottom bar going across is showing you number of months, just like at 1 year, 2 year, 3 year, and 4 is those highlighted portions. And then on the y-axis is showing disease-free survival, so people who don't have any recurrence of their cancer on scans. And you see that not just initially at the 1 year mark, but continued throughout. The upper bar is, the green is showing people who received pembrolizumab and that they have less rates of recurrence than people who did not receive treatment. Additionally, when they did further subgroup analysis, they saw that patients who, the higher the risk, especially those who had that one site of metastasis they were able to take out, that they had even bigger benefits from this therapy. For example, it showed that at 2 years, 37% of the patients with some smaller metastasis that was removed had recurrence if they received no therapy, compared to 78% remaining disease-free at 2 years if they got this 1 year of immunotherapy. So overall, immunotherapy is generally pretty well tolerated. Though, when you're telling your immune system to go out and activating it, essentially releasing some of those normal breaks, you can have side effects. And these are a little bit unique in that it can cause inflammation anywhere in the body. So when you see that ending on these words, itis, that's referring to inflammation. So you can have things like dermatitis affecting the skin, colitis of the colon. You can also have things like inflammation of the liver, your lungs, anywhere in the body really can have inflammation. So we keep a close eye on side effects in labs when you're on treatment to watch out for these things. Often these are very manageable. We're often able to continue therapy and just manage it with medications or small adjustments. But there can be serious long-term side effects that aren't going to resolve when you finish immunotherapy. For example, if you develop inflammation of the pancreas, you can develop what we call type 1 diabetes, where you're insulin dependent long-term. This is different from what you yourself or family friends may know people with type 2 diabetes, where through diet and exercise and medications, they may over time be able to reduce the need for meds. For them, even after they finish immunotherapy, they're still going to remain needing insulin long-term. So immunotherapy is really good, really well tolerated, but you do have to know that there are risks of more serious things as well. And each immunotherapy drug has some particular things that are more common with it than others. When we look at the category that pembrolizumab belongs to, we often see initially, early on, things like colitis, so that'll present with diarrhea, or dermatitis, so rashes, itching, things like that. And those often happen earlier on. But you'll notice on this graph it's showing a number of weeks. At day 1 or 2 after your first infusion, or even week 1, 2, 3, you often don't have many side effects. Some of my patients say, maybe I was a little bit tired for a few days after, like a day after. But these side effects don't happen immediately the way it may happen with chemo or even drugs that you may take for other non-cancer conditions. So immunotherapy being longer lasting means the side effects can present at any time during treatment, but often takes a little bit before you start to see those side effects. I'll go through a few of the common ones that we see, just so you have a sense if you go through immunotherapy of what we may be looking out for. Diarrhea is one that I see commonly. Not everybody gets it, of course, but a lot of people do. And often it's just as simple as a little bit of a few loose stools per day. and often it's very manageable. Some people don't need any medications. Sometimes, though, we may use anti-diarrheal medications like over-the-counter loperamide or Imodium, which some of you may have used in the past yourselves. If it's more severe, though, we may need to, say, hold immunotherapy and even give things like steroids or other immune-modifying drugs to help essentially stop that activation of the immune system and the effects on the colon. Another really, really common one that I see is rashes and itching. These often are very mild. We use things like topical cortisone creams and then some antihistamines like your Zyrtec, Claritin, things like that to help with the itching component. And people do really well with that. Sometimes, if it's more severe though, we may need to hold therapy. Even sometimes rashes can be severe enough to be really significant, need hospitalization for more IV steroids and closer monitoring. So that can happen. Often just manage outpatient through simple medications. And then hypothyroidism is a common one that I see on labs. It happens when the immunotherapy causes inflammation in the pituitary gland, which helps downstream regulate your thyroid gland. So if your thyroid gland stops producing its thyroid hormones that it used to produce, you will first start to see changes in labs, and often we catch it there before patients even develop any symptoms. Sometimes they may have symptoms which can be feeling a little more fatigued than they used to, having some dry skin, constipation, maybe noticing some weight gain or feeling more cold easily. And the treatment for this is giving thyroid hormone in the form of a pill. It's a common medication. Many of you in this room may even have taken that even before having kidney cancer. It's a very common thing. So it's very easily managed, but that's often a long-term medication, even after immunotherapy. So you heard me mention steroids a few different times here. Steroids work because with how long-lasting immunotherapy is, its effects don't leave the body within a few weeks or even months, even after your last dose, if we say hold a treatment because you're having some increased side effects. We have to find a way to essentially calm down the immune system, and we do that with higher doses of steroids. Often it's done with oral steroids like prednisone, but sometimes you may have to be in the hospital to get some IV steroids initially. And so when it comes to steroids, that comes into the picture here when we're thinking about people who come to us who have a history of autoimmune diseases. These patients, they at baseline already have a disease where their immune system is a little bit dysregulated. It's already attacking their own body. So we don't want to give them immunotherapy and cause worsening of their underlying autoimmune disease with this medication. So sometimes in those people, they may already be taking things like steroids or immunosuppressive meds to control their autoimmune disease. Immunotherapy would be counteracted by those high-dose steroids. So if you have a history of an autoimmune disease and then need treatment with immunotherapy, we may say in this adjuvant setting that that's not the best option. Let's just monitor you with scans every 3 months instead, or periodically, rather than giving you therapy. Since, as you saw in those graphs, a lot of people who have their kidney cancer surgically removed don't even have any recurrence. So what does that 1 year of treatment actually look like for patients? It's generally an infusion every either 3 or 6 weeks. Most often we do every 6 when it comes to adjuvant therapy. You get labs before each dose. You come to clinic, we go over those labs, any symptoms you may be having, make any adjustments as needed, and then clear you to make sure that yes, you are safe to receive this infusion. We encourage our patients to reach out to us with any symptoms they're having, whether they're ones that we've talked to them about before, that hey, immunotherapy can commonly cause this, keep an eye out for it, or things you're unsure about. It's always better to reach out to us and ask, is this something I should be concerned about now, or is there anything I can be doing? We'll do scans even during this year of treatment to keep an eye on things and make sure that there's no evidence of the cancer recurring, no changes we need to make. When it comes to that 1 year treatment, you usually don't have any activity restrictions. My patients are still able to stay active, work, do most of their usual things without any major impact. So that's a really beneficial thing about immunotherapy and pembrolizumab. These side effects, we talked about being long-lasting, often will give you these little wallet cards for you to keep that say that I'm a patient who's been receiving this medication, so that if there's ever, say you go to the ER for something, or so you're not coming to your regular doctors, regular oncologists, people outside can know that, hey, I need to think about this as well. It's maybe potentially causing whatever's going on. So overall, pembrolizumab, Keytruda, is recommended for adjuvant therapy in certain patients depending on characteristics after surgery. But if for whatever reason you choose not to do immunotherapy to prevent recurrence, that's also very reasonable. And we just continue with surveillance scans. And there's still ongoing research happening into additional adjuvant therapy options and other ways to try to manage this going forward to get even lower rates of recurrence.